chance to pick up lunch. I want to thank several people for being here. One, I want to just acknowledge the TASH Board of Directors. They're in town this week for our meeting in Capitol Hill Day, and TASH is the sponsor of this event. I'm Bart Trader. I'm the Executive Director of TASH. TASH has a long history of advocating for people with significant disabilities. We believe everyone should have the opportunity to work, to learn, to play, and to be a part of their local communities as equal citizens. And we know that that's not happening as broad-based as we would like it to happen. So our work is still ahead of us, and we're glad that we have several new champions in the room today. I think you will be once you leave. We'd also like to thank our co-sponsors for today's briefing, including the SAMHSA, National Center for Trauma-Informed Care, the National Down Syndrome Society, the National Autism Association, COPA, and Families Against Restraint Seclusion. We'd also like to acknowledge all of our praise members. TASH is the lead of the Alliance for the Prevention of Restraint, Aversive Interventions, and Seclusion. We've been a coalition of national organizations since 2004 against the use of restraint and seclusion because of the dangers that it presents to people. We have 22 national organizations that are part of this coalition, and if you're part of an appraised organization partner, would you please raise your hand? Thank you, everyone. I'd also like to acknowledge Larry Wexler in the audience from the Department of Ed. Larry, thank you for being here. It's great to see you. Hi. And the rest of you who have decided to spend your time with us today to learn more about restraint and seclusion. TASH has been concerned about the practice of restraint and seclusion and other aversive behavioral interventions for more than 30 years. And about 13 years ago, the Hartford Current brought it to national attention, the use of restraint and seclusion in facilities around the United States. When that report was published, they quoted the Harvard Center for Risk Analysis as estimating that 120 deaths occur each year in the United States from the practice of restraint and seclusion. We don't see any alleviation of that, not yet, since it's still allowed in so many facilities. Last year, after the Government Accountability Office reported to Congress that restraint and seclusion was being used in public schools at a rate that we did not realize, and with dangers that people did not realize, TASH conducted a survey, and 1,300 parents responded in a period of 2 weeks to an online survey. What we found out of that survey, and this has now been published in our research journal, there's a link to that information in your packet today. The survey reported that the large percentage of young people who were restrained and secluded in public schools were between the ages of 6 and 10 years old. These are the youngest, the smallest, the most vulnerable children are being held to the ground and stuck in dark closets because people don't think that they're behaving appropriately. This usually happens to kids with disabilities that may demonstrate an impact of behavior challenge, but it's not because of willpower, it's not because the kids are bad, it's because the kids need supports that are not being provided. We were thrilled last year when Representative Miller and Representative McMorris Rogers introduced a bill that actually passed in the House that set a federal floor of protection against the use of restraint and seclusion in public schools for young students. And that bill did not pass the Senate, so we still do not have a bill. Representative Miller and Representative Harper from Mississippi have reintroduced this bill this year. It's the same bill that passed last year. It's H.R. 1381. if you don't walk out of this room with anything else, we want Congress to support, to co-sponsor this bill and to get it passed this year. It establishes protection but allows states to develop a lot of their own training tools. It allows states to develop strategies for how they're going to help schools down the road of prevention. It also prohibits the use of restraint and seclusion except for in the case of emergency, and requires parental notification and involvement in the planning to prevent challenging behaviors from occurring and escalating. That's key. Parents currently do not know that their children are being restrained or secluded in public schools. They just don't know. 70% of the parents that responded to our survey said they had no idea that it was happening. So our goal today is twofold: to gain support for the bill, but also to gain your support. And for you to understand that there is an urgent need to protect school children in the United States today against these practices. So, we're about to begin. All speakers will first speak and then we'll open the floor for questions. We hope you stay for the question and answer period. We have the national experts here to talk to you about this today. So I'm going to introduce our first speaker. We are thrilled that Joan Galice, the project director for the National Coordinating Center for the on Seclusion and Restraint Reduction and the National Center for Trauma-Informed Care, is here with us today. Dr. Galice developed trauma-informed programs for tomorrow's children, a program serving incarcerated women and their newborns designed to break the intergenerational cycle of despair, poverty, addiction, and criminality. Dr. Galice will share with you some of the lessons learned from the two centers she directs.
You're welcome. Thank you. Good afternoon, everyone. Barb has told us no more than 7 minutes. So, I'm going to try to look at my watch without my glasses and make sure I keep it to those 7 minutes, because I could talk about 7 days on this topic that is so dear to my heart. I've spent many years training in psychiatric facilities, working in forensic facilities, working with kids, and I can tell you, in very difficult environments of psychiatric facilities, the elimination of seclusion and restraint is possible. And if we can do it there, if we can do it in correctional facilities, we can certainly do it in schools. I want to tell you that there is nothing therapeutic about tying a child down. There is nothing therapeutic about closing a child in a closet. Actually, the opposite is true. It does not just do no harm, it does more harm. Oftentimes, the children that experience this kind of horrific trauma, it's a replication of the traumas that they've experienced other times in their life. We hear from adult survivors of trauma, adult consumers, that the experience of being in restraint replicated the abuse that they suffered from throughout their whole life. So it isn't just no harm, it's more harm. Imagine being a child and you're in school where you're supposed to feel safe and you're feeling a little dysregulated for whatever reason. And you get anxious and you throw something. And what happens? You're put in the seclusion and restraint. What happens to that child inside causes lifelong damage. It's not an acute event. It's that experience of being restrained, held down, causes lifelong damage. It's so important that we eliminate this practice so we keep those kids from being further traumatized and ending up in our adult psychiatric substance abuse systems, because that's what it does. These practices are horrific. It's time for them to be eliminated, and clearly, again, there is not one therapeutic value. We hear from adults who have experienced the seclusion and restraint as children, and I hear it from one woman who said the experience of being locked in the room replicated the abandonment that she felt when her mother would leave her with her 8 brothers and sisters and go off for days. So that abandonment issue, again, is only reunited. But the good news is, SAMHSA has taken the lead on preventing seclusion and restraint in our psychiatric systems, in our state hospitals, in our forensic systems, serving people who are coming from the criminal justice systems, and we have been extremely successful because we're about prevention. We so often respond after the event occurred. What we're about in terms of our SAMHSA work and trauma-informed care is creating environments where we reduce the likelihood of triggering someone in the first place. Creating environments that are calm, continuous, teaching kids who have dysregulated emotional systems how to self-regulate. Teaching them the strengths that when they start to get upset, they know they can use a weighted blanket or hug a stuffed animal that vibrates or color a picture. How we can front and load to prevent this from happening in the first place. It's about strength-based, it's not about deficit-based. And this is not just good for the children that we serve, it's good for our staff, because the process of secluding or restraining anyone is traumatizing for the staff too. And we sometimes think it maintains order and it keeps people safe. Quite the opposite is true. Seclusion and restraint keeps no one safe, either emotionally or physically. So the elimination of this practice is critical, and it is possible. I'll tell you a very quick story before I close. I was in a residential program for kids in Illinois, and I was going to do a consultation with a facility that was having a very difficult time with a particular child. And I said, well, the child had just gotten out of seclusion and restraint, and I said, let's bring him out. And the staff was kind of in a horseshoe, and let me talk to him and see if we could figure out what happened. So they bring this young boy out. The staff told me, he'll never talk to you. He's cognitively impaired and psychotic. This is what they told me. And they said, and by the way, you better not put your pocketbook on the floor because he's going to go through it and take all of your things. So of course I put my pocketbook on the floor right next to me. I brought the child out. He sat there and had this conversation with me. He had been put in seclusion and restraint for throwing a chair. Didn't hit anybody, he threw a chair. I said to him, what happened before you threw that chair? Now this is my psychotic, cognitively impaired child, right? He said to me, as clear as can be, someone said something about my mommy. Okay? Well, it was the day mother was supposed to appear at this residential facility, and she never came. So he's vulnerable. He is feeling exposed. He has that vulnerability. What does he do? He picks up the chair and throws it because he did not know what else to do. So I said to him, before you threw that chair, does anything happen to your body? Does your body tell you you're going to get upset? As clear as can be, remember my cognitively impaired child, he said, I shake my leg really fast. So okay, there we were able to connect the dots with him. We knew the vulnerability. We knew that he could identify this early warning sign. And I said, what could we do that would help you? If those visiting days came and mother didn't show up, what would help you? As clear as can be, he said to me, if I could just draw her a picture or write her a letter. Not rocket science, right? Simple solution that prevents. Now, the staff never gave him a pen or pencil. They never knew what was going on because they thought he was going to hurt people with that pencil. But when the staff understood, when they got it, that we can prevent this from happening, they got him a marbleized notebook and a big, thick magic marker, and that child was able to color or do whatever he could on those days. That was visiting days, because if mother doesn't show up, he was feeling vulnerable. And that's what we can do. That's what we can do. We're such a response-driven system. We're very good at that. But we need to intervene at that stimulus level. And we need to help these children find that capacity and that strength to self-regulate. Because that's empowering for the child, and it also creates environment that are healthy for the staff. So in this era of war and budget cuts and all of the difficult things that we deal with, we really have an opportunity to do something that takes so little money, but it saves so many lives, and I believe prevents the children that we are tying down now from entering into the adult system in the first place. So I thank you very much for your attention.
Thank you, Joan. I very much appreciate you being here. The second speaker is Phyllis Musamici, who is a parent advocate who has spent the last 5 years educating parents, speaking at conferences, and with Florida legislators about the dangers and overuse of restraint and seclusion used on children with disabilities in the public school system. Phyllis is also the founder of Families Against Restraint and Seclusion, which is a blog she dedicated to families that are looking for help and to the children who've lost their lives or have been physically, mentally, and or emotionally harmed by restraint, seclusion, and other abusive practices. Phyllis.
Hi, good afternoon, everyone. I'm here today to talk about how our family became involved in restraint and seclusion and aversive practices. That's my son Christian over there. Christian had always been a very happy child, and he loved going to school and he loved learning new things. But in 2005, when he went into middle school, all that changed. At the beginning of 7th grade, I started getting a lot of phone calls from the school telling me that he was being disruptive in class and that he was getting aggressive. I didn't know any of this because he wasn't doing any of this at home, so I didn't understand what was going on in the school and why they were having problems with him and we weren't. Most of the days that I would pick him up from school, his desk was out in the hall and he was isolated by himself. He had a one-on-one aide, but she was never with him. And seeing him like this broke my heart. But I was very trusting of the school district and very naive at the time and thought that they knew what they were doing. They were the school districts, they were the professionals, and so I allowed them to isolate him in the hall. When I look back at it now, I know I did the wrong thing. By 7th grade, by mid-7th grade, we started seeing behavior changes at home. He once was a very happy little boy, and now he started having problems with aggression and fears and phobias. Several times when he came home with bruises, I asked him what happened, and all he would tell me was, "I fall down." When I checked at the school and asked the teachers, nobody knew what happened to him. So because his expressive language is very poor, I was never able to get very much out of him. He was so distraught by the end of 7th grade that we pulled him out of school the last 4 days and kept him home to seek medical help. By the end of the summer vacation, he seemed to be doing a little bit better, so we put him back in school. It was not a good choice. He started getting upset again and started having issues in school again. He would cry in the morning and tell me, "No school, Mommy, no school, no like, no like." And I didn't understand why, because he loved school, so I couldn't understand what was going on. A little over a year after this happened, we wound up pulling him out of school again because we could see that it just wasn't working and he was getting more and more upset and more distraught, and we felt like we were losing him. So we put him on hospital homebound, and about a year later, I had an advocate approach me about restraint and seclusion, and she asked me if I had requested any of the restraint logs. And I said, "No, what are restraint logs?" And she explained to me, and never in my wildest imagination did I ever think that something like that was even a possibility. Excuse me. About 4 weeks later, I got the restraint logs, and I was shocked to see what they said. My son had been restrained, that was documented 89 times in 14 months, and I never knew about it. I was never notified, not even one time in writing or by phone. We requested the restraint logs for 6th grade also because they weren't there, and I was told that they were missing. We tried to get help in locating them to find out what was missing in this picture, but nobody would help us, not the local school, not the Florida Department of Education. We also found 2 pictures of Christian that he had drawn on his computer. And because he doesn't have good expressive language, we realized that this was his way of explaining himself. The first one is called Christian and the second one is called Tears. And it was very upsetting to see that this is what he was feeling. We filed a complaint with the Department of Education, but no action was taken. They found no fault to the school district. There were documents that were falsified by the school where they circled on every line that was parents notified. This wasn't true, but nobody would listen to me because the school districts turned this documentation in, even though it was falsified. They believed them and not me. There was also written on the report that they brought me in and demonstrated restraints on me. This never happened. And it was obvious that somebody made it up, but when I requested documentation on that, there was no documentation that they could give me. So they must have taken a verbal from the school district, which doesn't tell you anything. That's not an investigation. We contacted also the Department of Children and Family Services, and they investigated and they wrote up some indicator of mental injury. But that was all they could do. There was nothing else they could do. They said they had no authority over school districts and there was nothing they could do. On March of 2008, we had to put Christian in a residential. He was just too far gone. I couldn't take care of him anymore, and he had just lost interest in everything. It was like he gave up on life. And he was starting to get aggressive with me, and everything that we tried to do to help him wasn't working. We were also told by the school districts that what happened to our son was an isolated incident. But I just didn't feel that that could possibly be true, that my son was the only person that was restrained and put in isolation. So I started checking around, and what I found was parents all through Florida that had children that had been restrained, put in seclusion, isolation, tied up, hit, pinched, arrested, suspended for their disabilities, for things that were out of their control. Parents have nowhere to turn. They have no place to go to get help because everywhere they turn, they're told we have no authority over school districts. We're working with a broken system, and parents have no place to turn. And I just couldn't believe that this was true, but it is true because I spent days and hours on the computer and on the phone calling people, and not one of them, not one, would help me. When this happened to my son, I didn't have anywhere to turn at all. As I met more parents and realized that they didn't have any place to turn, I decided to create a place where parents could at least go and talk to each other. So I created Families Against Restraint and Seclusion. And at least this way, we were able to unite together, talk, and I was able to hook parents up with other parents in their own city and later in their own county and later in their own state, because I started getting people from out of my state contacting me. I believe that the parent advocates that have worked with Families Against Restraint and Seclusion have made progress. It may not be the progress that we want, but I think we've definitely gotten things out in the open. And we now have FARS sites created by parent advocates so that they can work with other parents in Georgia, New Jersey, Missouri, and Rhode Island. These parents all have their own tragic stories to tell, but they're willing to give their time to try and help other parents and educate school staff and legislators about the dangers of restraint and seclusion. 5 years later, my son is still not the same. He has a lot of phobias, and he doesn't like to leave the house. He doesn't like people to go near him or touch him. He still doesn't have a lot of interest in things that he used to really enjoy, and he's lost a lot of his ability in school and also his social interaction. I do believe that school staff do need to keep things in order, but I don't believe that restraint seclusion and aversives are the answer to what needs to be done. There are so many other things that can be done in the school system, like ABA therapy, positive behavior techniques, and calming or sensory rooms. These children just need somebody that understands them and understands how to work with them so that they can better cope with their emotions. Families Against Restraint and Seclusion would like to see a federal bill passed and supports the appraise organizations for the work they are doing to get federal laws passed so that all children with disabilities will be able to go to school and feel safe. And I feel that we should all get involved because these children need us. They need us to get involved so that this law can be passed and that they can go to school and enjoy their lives and be protected and feel safe when they go to school. I'd like to close in telling you that in May of 2010, Christian came home from the residential treatment center. He's made a lot of progress the last 2 years, but he still continues to suffer from anxiety, phobias, and panic attacks. And our family continues to seek the medical help to address these issues so children like Christian and Christian will be able to enjoy his life again. I want to be able to have my son back the way he used to be, and I'm hoping that we'll be able to find ways to help him to get him back. Thank you very much for being here.
Thank you, Phyllis. Our next speaker is Michael Remus, who is the Director for Student Support Services for the Deer Valley School System in Arizona. He is also the father of 2 students with disabilities, one having behavior issues, and believes in making sure all students are included in their neighborhood schools with their peers and siblings.
First of all, just let me tell you it's an honor to be here to present an issue that's making news not only across our nation and our schools, but it is the water cooler gossip and around every staff member that hears all the things that are going on. As Barb stated, I work for Deer Valley Unified School District, which is the 5th largest district in Arizona. We have approximately 36,000 students, and it's spread across 367 square miles, which is the largest landmass district in the state, with 37 schools. We serve a unique population because we go from urban in North Phoenix, clear north, up to Anthem, which is very urban and suburban, you know, up in the what we call the North Hinterlands, because we're such a large district and looking at that. A third of our district is Title I. So, and again, another third is very socioeconomic in the high standard. Very few minorities, 2 major minorities in the south end of our district, primarily with an Hispanic population and looking at that. In special ed, we support about 3,200 students, which is about 8.9% of our population. 5 years ago, we served 14%. But because of hopefully prevention and other means put in place, our student population has dropped because of preventative measures and particularly our inclusive practices. It's interesting when we talk about this concept because all of our students go to their neighborhood schools. In other words, we do not bus any student to a cluster site. They have a right to be at their neighborhood school with their siblings and with their neighborhood peers. And what makes it interesting today is people always want to come and say, well, what do you do with students with behavior issues? Because in many districts we usually cluster, or what we say clump, students with behavior disabilities, you know, in one school or one self-contained classroom, etc., which makes it tough for staff to begin with. We found that when all students go to the neighborhood schools, everybody shares in the responsibility of what happens to students. So every child with or without behaviors attends their neighborhood school, again, with their siblings and neighborhood friends. Deer Valley believes in non-restraint and non-seclusion because we do not think this is a practice that teaches or that kids learn from that behavior. Unless we teach to redirect and put other supports in place, it doesn't make a difference in doing that. So if you followed the news, you know that students, again, in our state, we've had students that one student has died in recent years and serious injuries, just in Arizona alone. Schools should not be allowed to follow this practice that harms and even kills students. The reason I say that is if we really look at the intent of IDEA, the Federal Special Education Law, it specifically speaks to using positive behavior supports. This is totally goes against what is in our federal law that governs special education. The authors must have known the negative consequences used in the aversive practices, such as seclusion and restraint, as it does not work on students. Let me say it again, the law was quite specific when stating positive behavior supports will be used in schools, particularly for students with disabilities, as many of them do not comprehend the reason for a negative consequence. This is not to say that we are not prepared for a student that may become violent with him or herself and others around them. We have prepared our staff to make sure that we keep everyone safe when a crisis arises, and we need to prevent students from hurting themselves. But other measures are only to be, but this measure is only used in case of an emergency. We then put into practice what we learned from this incident so it does not happen again. Because many times once you get into seclusion and restraint, it's just an activity we go through, here's a consequence. Not only the student, but the staff does not learn from the incident, and that's why it goes on and on, rather than coming to a positive kind of reinforcement. We've also put procedures in place that if we have a crisis, we have all the documentation that it happened. Because as you just heard from a mother, she didn't even know things were going on. Parents are the last to be informed if there's incidents at school. So this includes what happens with the student. We have a form that we give to the parents, a letter. We do a debriefing within 24 hours with the parent and staff, and process forms for documenting any incident with the appropriate questions. This lets us learn from what we try to learn from the student and what they're trying to tell us, particularly if they don't have any language or communication. And hopefully it will not happen again. Thank goodness for the documentation. As just a month ago, we had protection and advocacy in our district because we did have a parent that was going to take and sue the district because of an incident that happened at school. But because of the prevention and whatever, and that's why I have a hard time understanding why many school administrators would be against this, it also protects us. Not only the students, but also the school when you have that kind of management between the two. Today I'm asking that the House, find more co-sponsors for keeping the House resolution intact and moving forward. I'm also asking that the Senate to introduce a companion bill that prohibits the use of seclusion and restraint, and that they particularly keep out the part of the IEP, that would drive it. I further ask that this law be passed for all students, because again, in our state alone, with the recommendations on our state task force is primarily geared towards students with disabilities. It should not be for any student, when we look at all students going to their neighborhood school. I will tell you, in our district, we've changed because of the recommendations from the state task force. We strongly feel that there needs to be federal law that sets out rules for seclusion and restraint, and we need to have something that governs us. If you were lucky enough to get a packet, you'll find that our Arizona bill, you will find what we've done at a district, and this is why I say it needs to go to the federal level, because we had a bill passed a year ago with just the task force to put things together and the recommendations. It went to all of the school districts, and they either had to adopt, reject, or modify. And even in the bill, there was no follow-up on anything to know if school districts literally did that. So we need some governance to know where are we headed in the future regarding seclusion and restraint, because this is no way that we treat children, and certainly cannot pass for that being an education. So again, I would ask you that you give us the guidance in such a controversial area so that students are not going to be continued to be hurt through these practices. So hopefully you'll look through that packet today. You will hopefully, I would love to have any of you come visit. And again, I would love to visit with other school districts, because we need to stop the abuse, particularly from restraint and seclusion, that are happening at our schools today. Thank you.
Thanks so much, Michael. Next, we have Linda Bambera, who is a professor from Lehigh University. Her expertise is in developmental disabilities, including children who engage in challenging behaviors. As a researcher, Linda has published numerous articles and books on positive behavior support, which is an evidence-based practice that provides positive alternatives to punishment and restraint.
We could try doing the dance, but a lot of it's animated.
Just tell me when to push it.
Okay,
I'll
well,
go.
we're
Whatever
gonna
you-
try.
I'm here for that.
So typical for a university professor, you have to have PowerPoint. That's just the way it goes. But I hadn't planned how we were quite going to do the dance, so forgive me.
Yeah.
So my area, if we go to the next slide. So my area of expertise is in developmental disabilities, as Barbara said, and particularly for individuals that have challenging behaviors. And I've written quite a bit on the topic of positive behavior supports. Those are evidence-based strategies that we can use as alternatives to punishment to reduce challenging behaviors. But in addition to my academic expertise, I also have lots of clinical expertise too. At Lehigh University, I run 2 programs that supports adults and adolescents with developmental disabilities to live and work in their communities. And most of the people we support happen to have very severe, challenging behaviors. Some were institutionalized, and we've been restraint-free since 1990. Okay, so I know that we can do this. What I want to talk to you about today are what are some of the alternatives to restraints. But before I do that, I want to drive home a few critical points in case you missed them. Okay, these are some of the things that our panelists had mentioned before. The first number 1 point is that restraint has no therapeutic or educational value. What does that mean? That means that restraint or seclusion does not improve behavior. Do you understand that? Okay. The professional consensus is that restraint, if it's ever used, should be used for emergency purposes only. So clearly, if the child's about to jump out a window, if a child's going to run into traffic, what should you do? Stop the child, correct? Yes. We don't need to have procedures on the books by keeping kids in 4-point restraint. Unfortunately, the types of restraint that we're against are the restraints not for emergency purposes, but restraints that are used to control children, restraints that are used to manage behavior, okay? When we use those forms of restraint, we're actually suggesting that our other interventions are ineffective. That makes sense? Right. We shouldn't be acting in crisis situations all the time. The other point I want to bring home, in case you missed it too, is even though people argue that we need restraints or seclusion for protection, restraint results in injury and results in death. That's not protection. Okay. So, why are we using it then? You have to ask that. I'm sorry if I'm laughing about that because it's just so crazy to me. Why are some even defending its use? Well, here are some of the underlying motivations behind that. The first underlying motivation behind why people will advocate for its use is because it's based on some sort of faulty beliefs that some kids' behaviors are so challenging and so difficult that they're beyond our therapeutic control, and the only tool we have in our toolbox is to be able to use restraint or seclusion. That belief is based on fear, and it's illogical. okay? Because we just established already that restraint can result in death, so it's highly illogical. The other underlying motivation is that when we advocate for the use of restraints, we really are demonstrating our lack of knowledge about other alternatives. And research is very, very clear on this point. We can reduce the use of restraint when people are properly trained in their alternatives. So we put the two together. We have faulty beliefs that they're necessary, lack of training. Those two things together result in the use of restraint or seclusion. Okay, you following me? Okay. So what I want to do now is, okay, let's go to the next one. I don't know if you could read that. So the critical questions are this. This is what you should be thinking right now. Well, is it possible really that we could educate students that engage in some challenging behaviors without the use of restraint and seclusion? And what are the alternatives? So what I want to do now is illustrate two descriptive studies that I'm aware of that illustrate how beliefs and lack of training play into our use of restraints, and then also give you some ideas about what are some of the alternatives. So the very first study that I want to talk to you about was a survey study. 72 administrators from private schools that support kids with emotional behavior disorders were interviewed. Okay. And what I thought was fascinating about this is that 95% of the schools said they used some sort of restraint. 95% of the schools said they used some form of restraint. What was interesting was the variation. 33% reported 1 to 3 restraints per week, 9 reported 1 to 3 restraints per week, and 3 schools reported 3 per day. Now I'm going to ask you, are these emergencies? Okay. They also, the survey also asked administrators about their beliefs. Interesting. Next slide. Okay, whoop, not next slide, but next point, okay. 68% of administrators believed that restraint was necessary for safety. 41% thought it was therapeutic. And get this, this is very exciting to me, 5% believed that restraint was unnecessary. Now that shouldn't be surprising to you because of the same 5% that reported they did not use restraints. You see how beliefs and practice go hand in hand. Let me give you one other illustration, and this one's closer to home. I want to present a case study from the Centennial School, which is part of Lehigh University. It's an approved private school for kids with emotional behavior disorders. It provides supports to about 100 kids per year. So it's a pretty small school, as are most residential schools for kids with emotional behavior disorders. Okay, look at the data. In 1997 to 1998, there were 1,064 episodes of restraint. That's an app for 76 children. That's an average of 14 restraints per year per child. Right? Now, look at this one. 82% of the workman comp claims were restraint related. Yet people continue to believe that restraint is there for protection of staff and individuals. 82% of the workman comps claim. This was going along at the same time when Centennial School had a policy that said restraint and seclusion should only be used for emergency purposes, and yet they were used otherwise. So, in the years 1998 to 2000, Dr. Michael George, who came in as a new principal of the school, started the process to reduce the number of restraints. And so what I want to share with you are some of the key elements for reducing restraint. Fortunately, we're not going to have time to go into all of them in depth, but I just want to give you some of the big ideas. The very first thing he did was sit down with his staff and create a shared vision. And he asked a very interesting question to his staff. He said, what do we want for our students and what do we want for our school? Very rarely will teachers say, we want to restrain our children, right? The answer is, of course, they want our children to be healthy, safe, well-educated. He also asked, what are your beliefs then? Why do we think we need to use those restraints? Okay? And then, as we are trying to eliminate our restraints, what do we need to put in place so that you're convinced that these alternatives will work? So they made a commitment to take data collection, essentially. So the next key element was making sure that there's strong organizational structure for change. There's a strong leadership and time built into the school day for teachers to be trained. How did they train the teachers? The very first thing they focused on was creating positive classroom school environments for all kids, not just those who act out, all right? Why? Research has shown over and over again that problem behaviors occur when teachers in general use poor classroom practices, okay? So the first level of training was to get teachers to change their curriculum to make sure that it was meaningful and relevant to the students, built in more opportunities for choice and control for the students so they feel empowered, teaching the children to take time instead of being timed out, teaching children to problem solve, engaging anger control, and also now teaching teachers to respond in emergencies in non-confrontational and in non-physical ways. There are alternatives. For those few kids that don't respond to general classroom practices, the next step would be to implement effective, individualized, positive behavior support plans that are based on research that is shown to be effective. I don't know how more to underscore that, okay? What does that include? That includes, one, we do an assessment to understand why children act out. So when we use restraints, we're not asking that question why, we're just applying it. And then, once we understand why, the next step is to develop interventions that focus on prevention and teaching and how to respond so that we are not touching children in ways that are hurtful for them. And then finally, the last key element to success is to use data-based decision-making. So that school made a commitment to look at how many restraints have been used per year and how many restraints are used individually with kids. And if those numbers don't go down, let's revisit and ask why and let's change. So let me just share the outcome data for you. In 1997 and 1998, there were 1,064 restraints. There was no data on timeout or seclusion. In 1998 to 99, they reduced it down to 327 restraints, but look at this, there were over 15,000 minutes of seclusion, and that was better than the previous year. Unfortunately, we don't have those data from the previous year. Okay, in 1990 to 2000 to the present time, there are now 0 restraints, 0 minutes of seclusion. Okay, it's possible. So the take-home messages: restraint and seclusion have no therapeutic value. Restraint seclusion is harmful, can be deadly, and there are alternatives. Thank you.
Okay. Thank you so much, Linda. Our next speaker is Dr. Janice LaBelle, who is a licensed psychologist with the Massachusetts Department of Mental Health and oversees children's inpatient and residential services. She's been leading her state's Restraint and Seclusion Prevention Initiative for the past 12 years. She's researched and written extensively on restraint and seclusion and trauma-informed care, and is a member of the teaching faculty funded by SAMHSA to reduce restraint and seclusion use around the United States. Janice is going to speak about the business case for reducing restraint and seclusion.
Oh, good afternoon. In the interest of time, I have given you a copy of this presentation, so you have it. But I also like to say things with pictures. So we're going to have this fast voyage, an aerial view through these slides, and I'm just going to tease out the important pieces from each slide. So this is a test of my speed speaking, your listening, and Dara's fast facilitation.
Thanks.
But thank you, and thank you to TASH for this great honor being here today. Okay, so this is the ground that I'm covering. Next slide. Violence in schools, is it a problem? Yes, it is. How do we know? The media tells us so. The literature tells us so. This is data directly from the CDC. Which comes first? Violence and seclusion and restraint, or seclusion and restraint and then violence? Ooh, we have a chicken-egg problem here, folks, because we know that violence is the gateway to seclusion and restraint use, but once we start using it, we have a toxic, vicious cycle, and seclusion and restraint can maintain and reinforce aggression in the school. Bad problem. Cost attached with restraint and seclusion, is there? Oh, you bet there is. Unfortunately, it's not been well studied. It's not been well studied in healthcare, but it has been well studied in the business world. So we take that cost model that's already been developed from workplace violence studies. We know that costs are incurred at 3 different dimensions: systemically, at the school level, and then at the personal level. So let's quickly talk about what those look like. Any service sector, I don't care what service sector it is, that uses restraint and seclusion is driving up the cost of that care automatically. It takes time, it takes staff, it takes training, it takes oversight and monitoring, ka-ching, it drives up the cost. These are, too fast.
Sorry.
When we use these procedures, they are dangerous, they are violent, they are high risk, as you've already heard. People can be seriously harmed. This drives up the cost of healthcare utilization. In mental health and behavioral health, for the last 10 years, we have declared that restraint and seclusion are a failure in treatment. The corollary is true in education. This is educational failure. This is lost time in learning. That child being restrained and secluded is not receiving an education, nor are the children who are witnessing that event. Next slide. Good, Dara. There are costs experienced at the school level if seclusion and restraint is used. There are operational costs. There are human costs. Each and every one of these bullets that I'm not going to read to you because you've got it to take home has a price tag attached to it. Next slide. If the school is going to use restraint and seclusion, well, buckle up because it is extraordinarily expensive and time-consuming. There has been only one study doing a time, motion, cost analysis of restraint use, and that is mine. A 1-hour episode claims more than 25 tasks and takes 11 and a half hours in the aggregate of staff time to implement. It is far more time-consuming and costly than people are even remotely aware. If a school uses restraint and seclusion and there is an untoward occurrence, we can see schools forced into closure, litigation in the form of millions of dollars, and worse, what economists call opportunity costs. I call them lost opportunity costs. This is the price tag of what's not happening because of restraint and seclusion, because that child's education has stopped as well as their peers and so much more. Next slide. Cynthia Conrad, a researcher from Connecticut, tried to assess what is that lost opportunity cost over a lifetime when there is a harmful event inflicted on a child by someone in a caretaking role. How does that translate over the course of a lifetime? We talked about substance abuse or incarceration or psychiatric history that will follow. She calculated per child more than $6 million cost over the course of a lifetime. Hugely expensive. What's happening to our children in schools right now if restraint and seclusion is being used? They are being criminalized and they're being pathologized because school districts have the speed dial to the police and they have a speed dial to the ambulance. As one school district leader told me, it's a race to see who's going to get there first and who's going to show up. That's the pathway that will then chart the course for that child. In this poor child's situation, he had felony charges pressed, he had a criminal record established from fighting against being restrained, and then he was psychiatrically hospitalized. It's unconscionable. Next slide. And this little boy, this just erupted in my state last week. I got a call from little Andy's parents. They are beside themselves because the school's medical director, at the request of the school administration, requested that this child be restrained twice a day. He's not restrained at home, during mealtime, in the Rifton chair, which is a small chair, the arms and legs strapped in. Parents said absolutely not. We don't restrain him at home during mealtime. The child's pediatrician said absolutely not. He doesn't need to be restrained. This physician issued this order for indefinite restraint use twice a day without ever having seen this child and then refused to speak with the parents. So we see a parentectomy, the parent authority being completely eclipsed. What does this mean for Andy going forward? We don't know. There are some costs that have been identified in the literature to move away from restraint and seclusion use. However, in my experience, in my state, most organizations simply redeploy existing dollars. Next slide. When you successfully move away from restraint use, the cost advantages are profound. When staff have the tools to know what to do differently, guess what happens? They don't get hurt. They don't call out sick. They don't leave their jobs. You will see a huge reduction in all of these staff impact costs. Turnover reduced, new hiring reduced, sick time, replacement time, workers' compensation, dramatic reduction, medical claims costs, huge reductions. And what happens to students and people receiving care without restraint and seclusion? They take advantage of the service that's being afforded them. They do well and thrive in that environment, and we see success in the community, so it's all good. We know there are positive efforts underway. PBIS, Positive Behavior Interventions and Support, a great prevention framework to really start to address student behavior, not used across the country, but where it is being used, schools do cite the benefit of it. New York State organized a coalition of their special education providers. They've now developed an initiative, Alternatives to Physical Interventions. They're moving forward. Next slide. In my state, I'm very pleased. We've been working on restraint and seclusion reduction within mental health for the last decade. We have now branched into all child-serving state agencies. Our Secretary of Health and Human Services saw our great reductions in costs, and she said, we're moving forward. Every child-serving state agency has now signed a charter that's adopting NASH's 6 core strategies to move away from restraint and seclusion using a platform of trauma-informed care. We are moving forward. Private sector is doing this as well. This is the Grafton School. Interest of full disclosure, I just became a brand new trustee at this organization. They were the most transparent and willing to share not only their restraint data, but their economic data. They work with a very challenging population from 7 years to 68 years of age with developmental disability. They offer a range of different services, but they are dedicated to moving away from restraint use, have reduced on the order of 99%. It was nationally recognized. Next slide, Dara. We see huge reductions in the costs that they have formally incurred. We see a reduction in injuries and turnover. Next slide. And what they have declared is a dramatic return on their investment on the order of $1.5 to $2 million a year in reduced staff costs and liability costs. Next slide. We know there are great pockets of success, but we know so much more needs to be done. Go ahead, you can do it.
Oh.
There you go.
Oh, I thought you were going to read that.
It's
Sorry.
the take home. No, everybody's got that to take home. Here we go. So I leave you with this final pitch to please support House Resolution 1381. We need co-sponsors. We need a companion bill because these are devastatingly traumatizing practices that have no business being used in a school setting where these are places for really for teaching and learning. These are expensive procedures to use only as a last resort. They conflict with the purpose of schooling and healing environments. We know that when we move away from these procedures, we save a lot of money and we're much more effective in restoring quality and providing a better education for children. So I thank you so much.